Thank you, BOS, and thank you, Abhay and Dinshaw. So, I have put in special efforts to make this a very simple but a practical day-to-day outpatient talk, and especially for the residents and the trainees. It's extremely important to know how to clinically examine a shoulder, because a large part of your success in treatment is going to be based on your clinical assessment and not on imaging studies. Especially because this kind of art, you may not get it purely through books. It comes with experience. Your surgical decision making is based on clinical examination, as I just said. And the most important, what Abhay said, is when not to operate a particular surgical procedure in this class of patients. So let me give you examples to highlight what I have started off with. So just look at example 1, 66-year-old male. MRI picture looks like a very terrible. Can I have a pointer? If you look there, infra is gone, supra is gone. Another example, 64-year-old male. Look at the tendon tissue there on the upper cut, the coronal cut, and lower down you see that there is a, again, infra tear. Example 3, 69-year-old male, very large rotator cuff tear, again involving the supra and infra. But what I want to share with you is all these tears on MRI, it looks like may or may not be repairable. But all of them were repairable. I repaired all of them with successful result. So this is to highlight that when you clinically examine, you can know even more than the MRI whether this cuff is going to be history and clinical examination. And this, in contrast, is an example of a truly irreparable tear which underwent a reverse shoulder replacement. So now coming to clinical examination. So why it is important? The shoulder is the most mobile joint in the human body. It has functions which other animals do not have. It allows you to reach various places, and the best part is the shoulder joint lends itself for clinical examination. What do I mean by that? I can challenge you. I do not mind standing here and challenging any of you that give me 10 patients with rotator cuff disease, and 8 out of 10 almost I will be accurately able to tell you that there is a cuff tear or not. Not only that, I can tell you what is the approximate size of the tear, which means it involves only supra, supra-infra or supra-infra subscap and teres minor. And I'm open to that anytime. So accurate diagnosis is the secret to successful treatment. Now we all know, this is an old slide, that majority of these painful stiff shoulders are not necessarily frozen shoulders, what is truly called as capsular fibroplasia. They are most of the time secondary capsulitis, secondary to this list of primary conditions. And if you look at it with a little perspective, all these are degenerative conditions of either the joint around the shoulder joint or of the rotator cuff. So when you have an elderly 40, 45 and higher age group patient with pain, almost certainly 9 out of 10, they will have some form of primary pathology, and the stiffness is secondary to that. So please do not label them as frozen shoulder, otherwise they get condemned into just exercise and doing nothing for it. A true frozen shoulder is rare or uncommon as defined by Zuckerman and accepted by the shoulder world. This is way back in 1994. And it is the true frozen shoulder, as I said, is not an inflammatory condition. It's just a random proliferation of fibroblast for reasons which we still do not know. But what we know is that there is more chance of this happening in diabetics. And the key to diagnosing a true frozen shoulder is stand behind the patient, try to passively externally rotate, and you will notice that there is almost a bony block, and it's the most painful movement amongst all other painful movements in the shoulder joint. So this, with a normal looking x-ray, is the key to diagnosing a true frozen shoulder and eliminating that from your assessment. Now that you know that how to pick up the true frozen shoulder, understand that it's a small percentage, then we come to the bulk of the painful shoulder, which is cuff disease. Now this is just half the list. There are almost 2 or 3 times this number of tests for rotator cuff. I'm only going to show you the ones which I do. So I almost always do a Job test, or you call it an empty can or a full can test. I do a Job test, I do a Hawkins test, and the main is I assess the rotator cuff power, and I'll show you in a little bit of detail how I do that. And of course check for the AC joint symptoms as well. Now this is, I think, one of the most exciting slides for me. I don't understand why nature gave us so many internal rotators but only 2 external rotators. If you look at the shoulder anatomy, you have subscap, pec, lat dorsi and teres major as internal. We have 4 internal rotators but only 2 external rotators. The implication of that I'll give in my next talk. But here is how I examine the supraspinatus. Very simple. It's not an isolated specific for supraspinatus, but yet you get a fair idea whether the supraspinatus is torn or not. We all know this test. I will not deliberate on that. How do I test for infra? With the adducted arm, you do an external rotation. Like I told you earlier, there are only 2 real external rotators. The teres minor is an external rotator in abduction. But so if you check in adduction, you will have a fair idea whether the infraspinatus is torn or not. This is I love this video. Look at this external rotation lag sign. You passively externally rotate, ask the patient to sustain that external rotation. He's unable to do that. So that's a classic, very typical infraspinatus tear. Then the hornblower sign, the same patient has an infraspinatus with teres minor. So with the arm adducted, he is not able to externally rotate. And with the arm abducted, he can. That means his teres minor is intact. His teres minor is intact. So he has to abduct to externally rotate. And that is truly a hornblower sign positive. Pate described this external rotation and give resistance to external rotation in an abducted position to check for teres minor. We all know the lift-off test of Christian Gerber. But you should know that in many of these shoulders there is so much of stiffness that is not able to, we are not able to execute this test. Then you can do the belly press or the Napoleon sign. Now this is a very typical massive tear X-ray with acetabolization of acromion. And these kind of patients we usually have a drop arm sign. So as soon as you leave support of the arm, it drops down, which tells you that it is a massive tear. AC joint, how do you diagnose a symptomatic AC joint? Very simple. Patient himself points to the AC joint, and if you just press on the AC joint, it is tender, and you can corroborate that with horizontal and vertical compression. You horizontally keep the arm and try to compress the AC joint, or you vertically keep the arm and compress the AC joint. So AC joint evaluation is essential clinically, because when you operate on the cuff, whether to do a Mumford procedure or not will not be based on MRI, because often MRI shows a degeneration in the AC joint, but it may not be symptomatic. So it's a pre-op evaluation. Of course, you must examine the scapula, extremely important to assess the wasting and scapular dyskinesia. And do not forget that the shoulder joint belongs to a human being who has a cervical spine, who has a diaphragm and a subdiaphragmatic abscess or a subdiaphragmatic disease can present with shoulder pain, and of course other causes of shoulder pain. I finish by saying, this is one of my favorite one-liners. I can't resist deleting from my slide. I'm not an arthroscopist because I cannot see pain through the arthroscope.